Hi, I'm Art Kaplan. I'm at the NYU Grossman School of Medicine in New York City, where I run the Division of Medical Ethics. I want to talk about an issue that sadly COVID made very clear over the past couple of years. It's how Americans die. Um, we've had sadly close to 900,000 plus deaths in the United States. And if you looked, there was a lot of complaint about the deaths being preventable. If you followed the debates and arguments, we obviously got into many discussions about what could have been done with masks or PPE or vaccines or testing to prevent that. But sadly, the deaths happened. And if you looked, you saw that a lot of the deaths took place in nursing homes, but many of them also took place in ICUs. And one of the problems that quickly became apparent was that people were dying alone. People were worried about the contagion of COVID in the first year of the outbreak. They didn't want to be in the room with a COVID patient. Similarly, at nursing homes, many people died by themselves without anybody in the room. No visitor, no relative, no hand holding, no nothing. By the way, that included my own mother, who died in a Massachusetts nursing home with my sister at the window and with me trying to talk to her on the phone. But it affected many people. I think that led to a discussion. It certainly did here at NYU. Some of our hospitalists and some of our palliative care people said, well, that's unacceptable. We've got to get more technology in there, more iPads, more iPhones, more ways, maybe even offering the chance to go into the room with PPE and taking a risk to a relative if they want to be with a dying husband, spouse, child, or grandma. And I fully supported that, and I support it to this day. But despite the fact that these issues were highlighted by COVID, the general question of how we die, where we die as Americans, predates the COVID epidemic. And I think we've got a problem that requires a general fix. If you ask most Americans where they want to die, something like 80% in surveys say at home. Now, that may not be realistic, but that's certainly their wish, that they would like to die at home, familiar surroundings, around familiar people. 60% of Americans actually die in hospitals in intensive care, and 20% die in nursing homes. So we've got a big gap still between what people want and what actually happens. Palliative care, a wonderful step forward in terms of supporting people who are dying, still is not utilized enough, even in hospital settings. And when it is, many people only get a week or 2 or 3 of palliative care before they die. They're still in that ICU bed, still under very intensive medical care for far too long. So a Lancet commission was formed, the journal The Lancet, the distinguished British publication, and said, what should we do? What can we do about this disparity between where people say they want to die, how they want to die, and what's going on in terms of how they actually die, both in the US and elsewhere. And I think a couple of recommendations came to the fore, which we all need to be thinking about. I think it's really important that physicians try to initiate discussions with patients and families very early about the possibility of death when serious illness, when a challenge is there that might really shorten one's lifespan. It's not that one has to simply give up hope. I'm not suggesting that, but among the plans and the possibilities have to be, if you've suffered a terrible accident, if you've had a terrible dread disease, you and your family, friends, partners, you need to hear what's going to happen if things don't go well. Very difficult to do. I know that. Patients don't want to hear it. Families want hope. Who wants to come around and trying to outline these kinds of grim tales? But I think it must be done. Otherwise, families don't have time to think about, could they take someone home? Could they hire help? Where in their culture is the best place to die? Sometimes it's at home, sometimes it isn't. What sorts of plans can be made for visiting? what sorts of arrangements can be made if they have to get the family or friends together within a time period of, say, a month or 2 months. When might they ask for palliative care if they don't want to pursue continued aggressive care? If we don't plan for it, and if we also don't encourage lawyers and religious people to plan for it, then how are we ever going to break this horrible situation of too many people dying under aggressive technology, surrounded by people who are masked with the lights on in the ICU, or very lonely in the nursing home? The other major step, aside from trying to plan, disclose, engage as much as really is possible, is to try and trigger requests for palliative care sooner. Many of my palliative care colleagues tell me they don't get called soon enough. There are things they might want to do to provide emotional support, sympathy, religious support, in addition to medical support, that they could initiate earlier than 1 week, 2 weeks, 3 weeks before someone passes. So I do think trying to take advantage in the hospital setting of palliative care and what it has to offer sooner is something we really got to try harder to do. And then let's use that technology that was invoked during COVID, those distant relatives far away, the multiple members of families that have, let's say, many different arrangements in terms of who's married to who and who's been divorced and who lives with who. They can all be engaged better, I think, using technology, using things like iPads and iPhones to bring them closer, to let them have more regular communication with the sick person. We have plenty of technology to keep the kidney going, a lot that we can do to measure blood gases, but let's start to use some of our technology to advance and enhance communication to give support to people who may be dying or who are likely to die. I think we could do better, and COVID tells us that we can and we should. So overall, I'm not saying we're really going to see a massive shift toward people dying at home. That would be probably too optimistic and maybe not even possible. But we sure can make it more humane, more consistent with the values of what people say they want when they die, if we shift more toward planning, discussion, and the use of technology to really make dying a more tolerable experience. I'm Art Kaplan. I'm at the NYU Grossman School of Medicine. Thanks for watching.